Namaskar, everybody. A very good morning to all our viewers joining us from America, and a very good evening to everybody here in India. Um, Before we start today's webinar, I take this opportunity to tell a little about American Academy of Yoga and Meditation. The American Academy of Yoga and Meditation is not-for-profit organization based out of Memphis, USA. The Academy is dedicated to education, learning, and research in the field of yoga with the endeavor of complete wellness for all. Through a series of dialogues, we bring to you the best in the field of education, healthcare from America and India. So, through the Ganges Mississippi dialogue, we intend to bring the ancient wisdom of the Ganges civilization and the modern approach of the Western world onto this platform. 4th February was celebrated as the World Cancer Day world over. Why do we need to focus on cancer? As per WHO, cancer is the second largest non-communicable disease in the world. And amongst cancer, breast cancer is the most common cancer in women all worldwide, all over the world. In fact, in India, 1 out of 22 women are likely to get breast cancer during their lifetime. We know that diagnosed early, breast cancer is known to have 100% cure. To know more about cancer in general and breast cancer in particular, we have with us Group Captain Dr. Tilak, a medical oncologist from Armed Forces Medical College, Pune, India, Dr. Shweta Kukreti Singhvi, diagnostic radiologist from Los Angeles, and Dr. Mamta Singhvi, radiation oncologist from Los Angeles. The moderator for today's program is Dr. Anjana Samadar. Dr. Anjana is a gastroenterologist and internal medicine specialist from Ohio. She has been actively contributing to community through her social initiative. She was a frontline doctor during the peak of COVID pandemic in USA, risking her life when she was critically ill due to the infection. Dr. Anjana, we thank you for your services. And now I invite you to lead this program. Thank you.
Thank you, Anjali, for your very generous introduction. I would first like to thank the American Academy of Yoga and Meditation for giving me this opportunity to moderate this very important event today. As we all know that breast cancer is by far the most common cancer in women worldwide, both in developed and developing countries. In low and middle income countries, the incidence has been rising steadily in the last few years. Like Anjali said, we have excellent speakers today to give us insight on breast cancer. I would like to first start by introducing our very first speaker, Dr. Captain Tilak, who is Professor of Medicine and Medical Oncologist in AFMC Pune. He has won several academic awards and trained under Padma Shri Award winner Dr. Lalit Kumar. He is Fellow of Indian Medical Sciences Academy and also Fellow of Royal College of Physicians and Surgeons in Glasgow. He has had several national and international publications. He is also joint editor of Indian Journal of Medical and Pediatric Oncology. His personal passions are running marathon, scuba diving, and long distance cycling. Without further ado, I would like to invite Dr. Captain Tilak to speak about lifestyle and cancer. Thank you, Dr. Tilak.
Thank you, Dr. Samadar, for the kind words and introduction. May I have the permission to share my slides?
Dr. Tilak, you need to share your slides. We haven't got your slides shared here.
Yes, I'm just.
Dr. Tilak, will you share your slides?
Just give me just a minute. I will just.
Okay, I think.
Yeah, here I am. I'm ready. I'm ready.
Okay,
I will just.
We don't see you here, Dr. Tilak. So
Yeah,
most
just a minute.
probably we are having too many guests logging in with us right now. So probably that's the reason we are not able to allow you into the studio with your presentation. What I'll do is I will run your presentation.
Oh, it's okay. I've made some changes, so I'm logging in right now. Just give me 20 seconds, and here I am. Right, I'm ready.
Can you share it?
And,
We can't see you here.
Yes.
We can't see you here.
Can you see me now?
Yes, we can see you. Perfect.
Good evening, namaskar, and a morning to all my colleagues in the United States of America. At the outset, thank you very much for this invite. And this is my alma mater. This is a place where I trained right from my MBBS to my MD. And currently I'm here posted here as a professor of medicine and medical oncologist. I'm grateful to the American Association of Yoga and Meditation, especially Dr. Indranil Basu Ray, and a special mention of Dr. Anjali Deshmukh for having given me this opportunity to present a topic which is very pertinent in the current era, that is lifestyle and cancer. Without wasting much time, let me just take you to a small icebreaker before I go on with the actual presentation. Please answer these questions on your own as to the question of the slides. Did you eat at least 5 servings of fruits or vegetables yesterday? Do you usually choose whole grains over processed grains, that is whole wheat bread versus white bread? Do you usually choose low-fat dairy items over full-fat? Do you usually take stairs over the elevator? If you're a male, do you have not more than 2 drinks per day? And did you exercise yesterday? If your answers to these questions are majority yes, then probably you have reduced the chances of cancer to a large extent. If you're a non-smoker, this particular risk further comes down. These are the Indian data, and cancer is the second biggest killer in the country. And the number of mouth cancers in India has gone up 129% from 1990 to 2013. Breast cancer is one of the commonest cancers in women, also the largest cause of deaths in Indian women. India also sees the highest rates of cervical, gallbladder, oral and pharyngeal cancers in India. And if you see the various causes of cancer among the population, 40% are because of tobacco and pan masala, mostly for lung and oral cancers, and 15% of causes are because of obesity, which causes more of breast, uterine, kidney cancer, etc. Only 4% of the cancers are because of purely genetic risk, which just means to say that most of the risks of cancer can be controlled by us. So what exactly is cancer? This picture shows what happens to a cell. Cell divides to make up the organ where it is situated. In case during the division, the cell has an abnormal structure, the cell undergoes a process known as programmed cell death called apoptosis. In the case of cancer, this particular apoptosis does not happen. The cell forgets to die and keeps on multiplying and accumulates more and more damages, thereby becoming more and more lethal. A common question which is asked is, what is a tumor? A tumor is nothing but an overgrowth of cells of a particular organ. It can be anything from a fat tissue to a particular lining of an organ. Tumor is usually of 2 types, benign or malignant tumor. A benign tumor is not actually a cancer. It does not spread by invasion or metastasis and just grows locally. As you can see on the slide, the cells here are limited to that particular lining of the organ. In case of a malignant cancer, which is a malignant tumor, the cells can breach the lining of the organ, can go into the vessels and invade various other organs, making it a malignant tumor. Let's see a small video
A
on
normal cell to a cancer cell. Take 5 minutes to get the picture. More than 60,000 billion cells make up the human body. They are the units that form the tissues which make up our organs, like the liver, heart, and lungs. When the body needs it, our cells split into two and replace those cells that are defective or have come to the end of their lifespan. This makes it possible for our tissues to preserve their shape and their respective functions with the passage of time. Every cell is therefore programmed to multiply and die. This ordered but complex program is controlled by the center of the cell, the nucleus, which contains chromosomes containing many genes made up of DNA. Sometimes, some of these genes undergo a change. The nucleus then sends out abnormal orders and the cell goes wrong. It multiplies uncontrollably and takes on a life of its own. Each new cell produced contains the same defect. The cells proliferate chaotically and form a tumor. This process may be short, but is often long. 10 to 30 years may separate the birth of a first abnormal cell from the appearance of a tumor of about 1 cubic centimeter. The tumor forms many blood vessels in order to survive. These will supply the tumor with oxygen and nutriments, allowing it to live and grow. This is what we call the phenomenon of angiogenesis. The tumor, however, only really becomes dangerous when the cancerous cells begin to invade through the vessels into the adjacent areas and spread to the surrounding organs. These cells can then invade other parts of the body, multiply and produce new tumors. Metastasis is the term used for this spreading process. But why does a cell become cancerous? There are many factors and they can exist to different degrees. Factors have been identified such as hereditary genetic anomalies, exposure to some viruses, HIV, hepatitis B, C and D, papillomavirus, Epstein-Barr virus, exposure to toxic agents, chemical products, radiation, sun, unhealthy behaviors such as the consumption of alcohol and tobacco.
So we saw how
A normal cell
develops in a particular person. So if you draw a graph and see what causes more cancers versus what is more controllable, on the x-axis we have which are the factors which are controllable, on the y-axis we have the causes of more cancers. We can see that majority of the cancers are very much controllable. Tobacco, diet, weight, activity, alcohol. These are causes of majority of the cancers and can be very much controlled. Inherited genes are cause of very few cancers and obviously they cannot be much controlled. Specific to breast cancer, if you see this graph, on the x-axis is the population which develops the cancer. On the y-axis is the relative risk of the breast cancer. On the left side, you can see the high-risk genes and the moderate-risk genes responsible for a few percentage of population causing cancer. On the right side, you can see most of the population getting the cancer because of low-risk alleles with added obesity, alcohol, oral contraceptive pills, menopausal hormonal therapy, etc. Below, you can see the factors which lead to reduced incidence of cancer in these patients. Breastfeeding for a duration of more than 12 months, regular exercise, and having the first child less than 25 years reduces the risk of breast cancer among women. Let's come to lifestyle and cancer. Now, Lifestyle is a very popular apparel store, and we know that it's quite famous among the women and children. It has a very nice tagline, and I personally like this tagline. It says, "Your style, your store." I've just modified it. It says, "Your style, your life." As we saw, smoking and alcohol use cause nearly 30% of most of the cancers in all over the world. The slide just shows the percentage of smokers across the world, right from India to Bangladesh to the Caribbean population, near about 20 to 25% overall of the world population smoking. And this slide shows what all elements and chemicals are there in a cigarette. You cannot imagine that the things like arsenic, lead, formaldehyde, turpentine, butane, cadmium, industrial chemicals which are supposed to be harmful, and they are found in the tobacco smoke. And this is the smoking related deaths in the United States. About 440,000 deaths are attributable purely to cigarette smoking every year. Not only cancers, but even ischemic heart disease, that is heart attacks, as well as lung disease are largely responsible for the deaths related to smoking. If 30% of the cancers are because of smoking and alcohol use, let's see what are the remaining causes. Another 30-35% are because of unbalanced diet. Diet which is very high in high glycemic carbohydrates, too many calories leading to obesity, a lack of physical activity, all these very much under our control. So let's see what does the existing evidence say. I have taken two cancers, the commonest in the male, that is lung, and the commonest in the women, that is breast cancer, to go across obesity, diet, and alcohol. Coming to obesity, this graph shows the prevalence of obesity over 1990s to 2010s. You can see there has been an explosion, almost like an epidemic of obesity all over the world. In breast cancer, there's a threefold increased risk with a BMI in the obese range. Patients who have a body mass index in the obese range that is beyond 30 kilogram per meter square, they have a very high risk of cancer. Not only do they have a high risk of cancer, they are more likely to have aggressive advanced tumors with a worse overall survival. And patients who have a very high BMI beyond 30 or a waist hip ratio of beyond 0.85 are associated with 11% decrease in overall survival. Similarly, in lung cancer, there is a positive association of high waist hip ratio in current and former smokers. However, the body mass index is related to race. A recent study published just 6 weeks ago in lung cancer in 2020 showed that underweight whites have poor survival than obese blacks. Asian, they did not find any association of BMI as a cause of death or survival. And underweight and obese female smokers have poor outcome, especially in the whites. Also, there is a very strange obesity lung cancer paradox. Patients who are having a high BMI or a normal BMI, body mass index, they surprisingly tend to withstand the surgeries and the treatment much better than those who are thin. This paradox is only seen in lung cancer and not seen in so much in other cancers. The real reasons are not known, but probably something to do with the various molecules which are secreted from the fat, which can cause the progression of cancer, as well as can help the body sustain the damages of cancer. Coming to diet, increased risk of breast cancer is there with intake of total fat, monounsaturated and polyunsaturated fats, and saturated fats. If there's a high saturated fat intake, the risk is much, much higher. High fat intake of hydrogenated fats or vegetable or corn oil, what in India we call it as vanaspati or dalda, these are associated with a very high increased risk of breast cancer. Similarly, in case of lung cancer, consumption of fish has been shown to slightly reduce the risk of cancer, but not that of dried or salted fish. There are protective effects of intake of tomatoes, lettuce, carrots, margarine, and cheese in the causation of lung cancer. There is also a reduction of lung cancer incidence with increased consumption of greens, fresh fruit, and cheese, whereas whole milk was associated with a significant increase in risk of cancer. There is also an increased risk of lung cancer with intake of meat, especially red meat, beef, and fried meat. This slide shows the protective effect of vegetables among various categories in cancer prevention. As you can see, most of the vegetables, green carrots, the tomatoes, the citrus fruits have got 70 to 85% reduction in the causation of cancers. Coming to plastics, which is part of the diet, we do not know sometimes which are the good plastics or the bad plastics. A good way to find out is just to turn the bottle upside down and watch for these numbers below. If there is a plastic which is produced in a correct manner, it will have a number. If it does not have a number, probably that plastic has not been produced in the right standards. If the number is 3 or 6, do not use that particular plastic. It is not meant for ingestion or storage of food items. 2, 4, and 5 are safe plastics, and any plastic which is produced industrially in a good manufacturing condition state will have the number of 2, 4, 5, which is can store edible items. Coming to alcohol, there is a high alcohol risk of cancer with alcohol consumption, but how much is the risk? With the weekly alcohol intake, the risk is about 2% increased risk. And there's a 4% increased risk for every each additional drink which is consumed. And if there is binge drinking of 4 to 5 drinks, the risk is almost double, 55%. Similarly, for lung cancer, there is a risk of association with consumption of beer and spirits. However, modest wine consumption may be inversely associated. Exact reasons not known. Probably there are some antioxidants in the wine which prevent this. And high mean lifelong ethanol intake, alcohol intake, has been associated with a higher risk of lung cancer. So when do you suspect cancer? There's a very nice mnemonic called caution. Suspect cancer if there is caution. C, for any change in bowel or bladder habits. A sore that does not heal. U, for any unusual bleeding or discharge. Any thickened or lump in the breast or elsewhere, it might be cancer, get it tested. Any recent indigestion or dysphagia which is persisting and not responding to routine medications. A wart or a mole which is having an obvious change, the color, texture, size, etc. And N for nagging cough or hoarseness. If there is any of these signs of caution, we must suspect cancer at various levels, at the general practitioner level, even at the hospital level. So what do we do? Since we know that majority of the cancers can be attended to or can be prevented by lifestyle, what are the lifestyle modifications we should do? We can begin a journey of 1,000 miles just by a single step. It's a very famous Chinese proverb. Let's look at two of the aspects, physical fitness and diet. For physical fitness, it is recommended to start slow and gradually build up the length and intensity of your workouts over a period of time which suits you and your body. As for recommendations, the physical activity should be of moderate intensity for at least 30 minutes a day or 5 days of a week, or vigorous and minimum of 20 minutes on 3 days of a week for it to be effective on the body. What are these physical activities? Among the moderate physical activities, we have, as on the slide, walking briskly, hiking, gardening, dancing, cycling, and mild weight training. For vigorous activities, running, cycling faster, swimming, aerobics, jogging, and weightlifting or competitive sports like basketball. What about children? This pyramid shows the what all these kids should do during their daily over a week. Every day, they should play outside, maybe pick up the toys, take the stairs, bathe a pet. 3 to 5 times a week, they should be involved in recreational and aerobic exercises. 2 to 3 times a week in strength and flexibility exercises and leisure and playtime like swinging or tumbling. And they must cut down on watching TV, video and computer games, etc., or sitting idle for more than 30 minutes at a time to have health benefits. What about patients who are already taking cancer treatment? What are the recommendations about the physical activity? Now we know that there is an effect of the chemotherapy and the hormonal therapy in patients who are taking treatment for cancer. There is fatigue, there is impaired muscle function, and there is reduced aerobic fitness. The effect of physical activity, as proven in studies, is there's a 37% reduction in the cancer-specific mortality, so more than 1/3 reduction in the mortality. There is reduced fatigue, depression, and anxiety. There is improved self-esteem, muscle strength, and flexibility, enhanced cardiorespiratory fitness and bone health, and a superior motivation, confidence, and mental attitude when physical activity is done during cancer treatment. The recommendations of WHO, World Health Organization, is the same: 150 minutes of moderate intensity during the week or 75 minutes of vigorous intensity during the week, with the body permitting during the therapy. A combination of both these can also be done for good physical benefits. How do you facilitate the physical activity in patients who are taking treatment? With good support for recovery and prevention, with the help of medications, etc., and counseling, these patients can be encouraged to undertake physical activity on a regular basis. If there are skilled instructors, they are very much effective in guiding these patients towards good physical activity. As we see in our daily practice, the instructors of yoga have come into a big help for us for patients of breast cancer in helping them see through the treatment and after that too. Company with peers, patients who are hesitant to do physical activity, especially because of losing hair or their physical appearance post-surgery, they feel better when there are other patients who are also doing the physical activity alongside. They shun the shyness. But then there are barriers. And what are these barriers? there are social factors. A lady taking treatment for breast cancer has to look after her home, children. There is issues of time and place, and these are the places where she can be helped and by the people at home to achieve good activity, physical activity. There are health-related issues, treatment-related vomiting, fatigue, nausea, etc. These can be addressed by the treating team to the best for the patient so that they can undertake some amount of physical activity during the treatment. Most important, lack of information. If the patient is not given the correct information regarding physical activity by the people at home or by the treating team, the patient refuses to take physical activity and feels that taking more rest is more important. Coming to the next one, the dietary changes. This slide clearly shows what all should be included for a healthy diet. Items which are colorful have a whole lot of antioxidant properties. Intake of beta carotene, vitamin E, and vitamin C through food items is definitely beneficial for a healthy diet. Choose a diet which is rich in a variety of plant-based foods. Eat plenty of vegetables and fruits, and maintaining a healthy weight and to be physically active is important as a matter of cancer prevention. If there is need to drink alcohol, drink only in moderation. Select foods low in fat and salt, and prepare and store food safely. But most important, always remember, avoid tobacco in any form. So to conclude, how can cancer be prevented? Avoid tobacco, eat healthy, avoid alcohol if possible, exercise, protect yourself from the sun, and get vaccinated against viruses which can cause cancer. Remember, your style is your life. I conclude my presentation and thank the American Association of Yoga and Meditation for this opportunity. My email is here. If anyone feels to mail me your queries, I'll be more than happy to revert with the answers. Thank you very much. Back to the organizers.
Captain Tilak, it was a very, very informative session, and it was very important how you re-emphasized that how diet and exercise plays an important role in our lifestyle and in prevention of cancer and developing of cancer. So thank you once again. We all enjoyed this session. Now, I would like to introduce another speaker who's a phenomenal speaker from Los Angeles, Dr. Shweta Sukreta Singhvi. She's a scientist and a breast radiologist with background in biophysics. Shweta graduated summa cum laude with bachelor's degree in biochemistry and honors biology from the University of Illinois at Urbana-Champaign. Following, Shweta joined the UIUC Medical Scholars MD PhD program. She pursued molecular imaging and technology development at the Beckman Laser Institute at Irvine, California. Shweta's research led to the discovery of biomarkers for breast cancer detection. Methods were patented, and results were published as first author in the Journal of Radiology. Since then, she has presented at various national and international conferences. Shweta's experiences includes device development for commercial prototype and clinical trials in conjunction with the American College of Radiology, Imaging Network, and National Cancer Institute. Shweta pursued residency in diagnostic radiology and subspecialty fellowship in breast imaging at the David Geffen School of Medicine at University of California, Los Angeles. In addition to research and medicine, Shweta has in-depth experience in education, including teaching in the Department of Internal Medicine and Physics at UIUC and biomedical engineering at UC Irvine. Shweta is a board-certified practicing breast radiologist. Currently, she serves as attending physician in a large private practice group in LA, California. She has broad leadership experience from writing curriculum for university leadership courses to leading large member organizations. Currently, she is on the board of directors for the American Physician Scientists Association. Shweta is passionate about mentoring students in science, medicine, and technology. In her free time, Shweta does Bharatnatyam and Kathak dance, enjoys long distance running, and delights in the French language. We are honored to have such a qualified person speak to us today about diagnostics in breast cancer and cancer. Without further ado, I would like to welcome Dr. Shweta Singhvi to come and speak to us.
Hi, good morning. Thank you very much for having me. It's quite an honor to be presenting to you today. So I'll just go ahead and share my slides here. Okay. So I've hit share. Can you see it?
Yep.
Do you see the slides?
Please go ahead. We can see the slides. They're on.
Okay.
Okay.
All right, perfect. So we're going to get into the nuts and bolts of breast screening and diagnostic evaluation in this talk. And again, thank you so much for this honor, and thank you so much for inviting me to present to you today. So we'll just begin with some statistics here. So 1 in 8 women has a chance of developing breast cancer in her lifetime in the United States. So that is approximately 13% of the population. Globally, this number becomes 2 million, which is the number of cancer-related deaths in women globally per year. So for 2021, the American Cancer Society estimates that there'll be about 281,000 new cases of invasive breast cancer. And there'll be about 49,000 new cases of carcinoma in situ. Invasive is when it's already spread into the breast tissue, and carcinoma in situ is when the cancer is still within the ducts of the breast. And the number is 43,600. This is the approximate number which has been estimated who will be dying from breast cancer in 2021. So breast cancer risks. We went through a lot of factors already with Dr. Tilak. Here are some specific ones to breast. Age. Breast cancer is often diagnosed after the age of 50. However, as you know, we have plenty of cases that we see earlier, way before age 50. Genetic mutations, the BRCA1 and the BRCA2 gene. Reproductive history, menses before age 12 and menopause after age 55. And what this gets at is the higher exposures to estrogen. Dense breasts. Detection becomes more difficult. The denser it is, the harder it becomes to literally see through the images. Personal history of breast cancer. History of breast diseases. For example, atypical ductal hyperplasia or lobular carcinoma in situ, which have an upstage rate. Family history of breast or ovarian cancer. And previous treatment with radiation, for example, therapy to the chest for lymphoma. So breast cancer survival data. And the message I want to get here is that we can save lives. If we find the cancer, which is localized, means it is only confined to the primary site, we actually have a very high statistical value of 5 years, almost 99% that we'll be able to have a survival. And then if it's regional, means it's only spread to the lymph nodes, it's 85.7%. And so as you can see, as it becomes distant, meaning the cancer has metastasized, the chances become much lower, about 28%. So again, the message here is if we find it at the right time, we're able to localize it and get it immediately, there's a high survival rate, very, very high. So screening. So according to the Society of Breast Imaging and American College of Radiology, the number that I want you to remember is 40. For a woman of average risk, annual screening mammogram should begin at age 40. And so here is just an example of mammograms. On the right side, you will see 2 images. They are on MLO view. And the left side or on the right side, you'll see the CC, which is craniocaudal, and on the left side, you will see the MLO. And these are basically 4 sets of images, which are typical images that we obtain for a standard mammogram. So what are we doing here? We're doing screening. And what is the purpose here? The purpose here is early detection. So the main message, as I said earlier, is that early detection saves lives. And so with mammogram, the sensitivity has been found to be 75 to 90%, depending on which textbook you read and which sources, but this is the rough estimate. And specificity has been found to be 90 to 95%. Mammogram has been shown to decrease mortality, and so then with early detection, a high sensitivity and a decrease in mortality. And so this is what we're getting at. For women over age 50, it is about 20 to 30%, and 40 to 49, about 15%, and even greater for some individuals. And what are we looking for? We're looking for a mass in the breast. We're looking for calcifications. We're looking for a distortion. Literally, the breast tissue can distort when there's something underlying. Now, ultrasound alone is not effective because with ultrasound, it uses sound waves, but it does not allow us to see through to find the calcifications. However, it has been found that ultrasound added to mammogram may, for women with increased risk, increase our ability to find cancers, meaning we have been able to find additional cancers per 1,000 for a normal defined mammogram. Now, I want you to have an idea that while we say that the screening age is age 40, according to the Society of Breast Imaging and the American College of Radiology, the other recommendations are also there. So, for example, the US Preventative Task Force recommends a mammogram every 2 years at age 50. And the American Cancer Society has a separate breakdown. So they recommend from 40 to 44, they say it's optional. From 45 to 54, they say every year, and after 55, they say every other year. So this is just for your knowledge so that you have an idea that there are different recommendations out there. So how do we calculate this risk? There are multiple models, but the one that we often go to is the Tyrer-Kruczek model. And so the important part of this model is that it includes not only age, height, weight, age at menopause, but it includes breast density, and we'll get into that in just a second here. And like I said, the higher the breast density, the more difficult it becomes to find that cancer. And the output here is the lifetime risk. And so it gives you the 10-year lifetime risk. And the number we are looking for is 20%. When we find that the risk is 20%, that's when our threshold starts increasing and we do further evaluation. So for those women who are high risk, meaning they have greater than 20%, who are they? For example, it would be a woman who has a BRCA1 or BRCA2 mutation, or someone who's untested but has a first-degree relative. For example, a mother, a sister, or daughter. So the point here is you need to start earlier. In fact, you need to start at age 30, but not before age 25. Another example, which is commonly seen, are mothers or sisters who were diagnosed premenopausal. So if you see that, if you as a patient see that, or you as a provider see that a mother or sister has been diagnosed, you need to start their mammograms early, starting at age 30 or 10 years before the average age of diagnosis of that patient, whichever one is the later time period. So other examples would be anyone where the calculations wind up greater than 20%, a history of radiation for lymphoma received between the ages of 10 and 30, and someone who has also had a biopsy-proven atypical cancer, for example, lobular carcinoma in situ, atypical lobular hyperplasia, atypical ductal hyperplasia, DCIS. Once that diagnosis has been made, it must be yearly. So the question becomes, when do you stop screening? There actually isn't a particular number, but what we say is when the life expectancy is about 5 to 7 years basis of age or comorbid conditions, or when the abnormal results of screening would not be acted on because of age or comorbid conditions. So screening ultrasound. This should not be routinely used to replace screening mammography. As I stated, screening ultrasound cannot see for example, calcifications. It can, and this, which is a big deal because calcifications, as you see them linearly or in a certain shape, is the beginning of DCIS. But screening ultrasound can be used complementary. And when would you use that? For example, a patient who has dense breast tissue, or a patient for whom you want to order an MRI, but it's not possible for some reason. Screening MRI, again, this should not be routinely used to replace screening mammography, but screening MRI can be used complementary to screening mammography in the event that the calculated risk is greater than 20%. So for example, someone with a BRCA1, BRCA2 carrier. And these are the people, for example, you would get them started on screening MRI. And you would rotate, for example, every 6 months, one mammogram, the other 6 months, the MRI. History of chest irradiation, for example, treatment for Hodgkin's lymphoma, you would start them 8 years after irradiation. And you may consider screening MRI depending on the patient and depending on the characteristics if it's a little lower, for example, 15 to 20%. So here is an example of an MRI. This is just to give you a sense of the images here. So on the left side of the screen in MRI, we have here a T1 non-fat saturated image. In the middle, we have STIR, which is water, so it uses water, and then post-contrast, meaning after the contrast. And what you see on the right side of the breast here is a multicolored lesion, and that is the cancer. This is just to give you another sense. So this is after post-contrast subtraction. We subtract out the contrast, and what we're left with, again, is a heterogeneous appearing mass. This is on sagittal view, and this is just a 3D reconstruction. These are just the different types of views that we use to allow us to characterize the malignancy. So how do we go about diagnostic imaging? And so in terms of the nuts and bolts of it, if you have a patient or you are the patient who comes in with breast lump, starting with age, if you are under 30 or the patient's under 30, we would begin with a breast ultrasound. And we would evaluate to see what the finding is. And then as deemed, we would attempt to add mammogram if needed. But if the patient is over 30, we immediately start with the diagnostic mammogram and go ahead and have the ultrasound as well. Furthermore, if we find that there is a suspicious mass there, we consider, and it should be considered, evaluating axilla for lymph node involvement. Sometimes it's done right at that time. Sometimes patients may end up coming back for that. So for example, axillary lymph node. Axillary lymph nodes can be enlarged even without a definitive mass on mammogram or ultrasound. And so this has to be then further evaluated. Cases of this could be that it could have metastasized, and now you have to start going and searching for the original cancer. Or a case of lymphoma where you won't necessarily see anything on breast, but you need to go search for that. Another case would be nipple discharge. If the patient presents with red or clear, unilateral, spontaneous discharge, start with the diagnostic mammogram and ultrasound. And then if needed, you would move on to MRI. It should be noted there's lots of patients who come in with bilateral white milky discharge. These are not on the threshold of what we would consider towards malignancy. Those would be more on the side of benignity. And then post-lumpectomy evaluation. Anytime a lumpectomy is done, we follow up with a diagnostic mammogram and possible ultrasound, depending on the case. So here's an example. Here's a female who comes in her 20s and she presents with a palpable. So she's under 30, we start with an ultrasound. And what you see here, these are ultrasound images, is a mass. It looks kind of dark. And so we would say this is a hypoechoic, which means darker mass. In parallel orientation, as you can see, it kind of looks horizontal. And this likely is a fibroadenoma. And the reason I bring this up is I just want you to understand it is very, very common for women to be walking around with these probably benign masses. And this is something we evaluate, we monitor, but this is not something that you necessarily need to worry about as cancer. Diagnostic evaluation. So this difference again, while this case was a fibroadenoma, this is just to bring to you that this here is a differential. And another differential of this is a phylloides. That, however, kind of looks like this, but the difference would be if you have a patient, a daughter, a sister who has a mass which is growing and they are young, it could be a phylloides and that would need to be excised. And of course, the other differential would be malignancy. So here we have a 52-year-old female who presents for screening mammogram. And this is very typical. This is daily. This is routine for us. We see 2 views, MLO, the right breast, the left breast, and we must search. And so now you can see this woman has dense breast tissue. And amongst this density, we have to search for the cancer. And this is the CC view. And this is what we do. We work to see what are we seeing? What are we able to distinguish between what's normal and what's abnormal? So here I went ahead and I circled the finding for you. That's the cancer. And the point that I try to bring out in these slides is that the cancer is quote unquote white on these images. And as you can see, normal dense breast tissue is also white. So it's a white on white background. And that's why this becomes difficult and a challenge in terms of trying to figure out what is the cancer. And that's just what we're doing in screening. We are going and looking at patients who are normal, who are asymptomatic, and searching for a malignancy. So here on the left, we have an ML view. It's the findings with circled. The findings also circled on the CC view. And that's a spot compression on the right side where you see that we have pressed down on the breast. So now what happens? So let's say we have a suspicious finding. What do? Well, you do an ultrasound-guided core needle biopsy or a stereotactic biopsy, which means using mammogram. Let's say the pathology demonstrates malignancy. What would you do? You would recommend surgical and oncological consultation. And then furthermore, you would recommend breast MRI for extent of disease, depending on the type of finding that you have, depending on the appearances. So pathology is then performed. Pathology reveals the receptors. What kind of receptors are on this malignancy? ER, estrogen receptor, PR, progesterone receptor, HER2/neu, in addition to a long list of tumor profiling, which is the molecular markers. And the whole point here is to determine what kind of receptors are there on the malignancy, which will then help the hematology oncology group to determine what kind of chemotherapy that they need to administer. Lymph nodes must be evaluated. As I said, breast cancer immediately moves to lymph nodes. So we quickly must evaluate the lymph nodes for disease progression. And then treatment. And I won't go into the details, but then the patient will get referred for chemotherapy, possible radiation. MRI for follow-up chemotherapy. When chemotherapy is administered, we often see MRIs being performed in order to determine any change in size of the malignancy as the patient continues their treatment. Next step. So like I mentioned, the fibroadenoma, this is something we typically do a 6-month follow-up on. The malignancy, as I mentioned, cancer, invasive ductal carcinoma, surgical and oncological consultation, which is the same for DCIS, which is also cancer, and it would be same, surgical and oncological consultation, as well as breast MRI for extent of disease. Sclerosing adenosis, that's a benign entity. You just go ahead and return to screening. And then the atypical findings, atypical ductal hyperplasia, a papilloma, lobular carcinoma. These have an upstage rate, so we recommend surgical excision. So this is just so that you know that once what we have found is of concern, it is a finding, what do you do next? So that you have an idea of how things would go next. So a standard report. Here is actually an example of one of my own reports. You have the exam title, you have this history, you have the findings, the breast tissue, the impression, and then the recommendation and a BI-RADS. And so when you see a mammogram report as a patient or as a provider, you have to have an understanding of BI-RADS. BI-RADS and breast density. So let's start with breast density. So on the most left side of the screen, you're going to see a very fatty tissue. Most of it is what you would say black in color. And the white part is going to be the fibroglandular tissue. So that would be almost entirely flat, fatty. And on the right side, extreme right bottom, would be extremely dense tissue. And now you can see there's so much fibroglandular tissue, now it's going to become harder and harder to find the cancer. But this is the variety of breast type tissues that we see, from fatty to heterogeneously dense on the left side to scattered fibroglandular on the top right side. These are the kinds of variety patterns that we see, and this is what we go with. So understanding BI-RADS, what is that? When you see a report, this is the standard which has been used. It's called the Breast Imaging and Reporting System. It was initially developed in 1993 by the American College of Radiology, and now it's in version 5. And so the entire point here that I want to show, this is straight from the BI-RADS Atlas, is that on the left side, we have the category 0, 1, 2, 3, 4, all the way to 6. And we actually define what it means. It means negative, it could mean benign. And then in the middle, we tell you what the next step would be. So it could be routine mammo. But if it's category 4, it's suspicious. And what's written here is tissue diagnosis, which means biopsy. Furthermore, BI-RADS has gone to the point of explaining what the likelihood of cancer is. And while category 4 is wide from 2 to 95%, it's been broken down into subcategories. And so 4B, for example, would be from 10 to 50. But this is an idea so that when you are reading these reports as a patient, because you will see your own reports, and as the provider, when you're providing these reports, both of you are on the same page of what the recommendation is, what the assessment is, and what the management is. Now, tomosynthesis, we use digital tomosynthesis. This means that it's basically a method by which the X-ray tube rotates in an arc about 15 to 45 degrees to obtain a low-dose set of projections, which are taken through the compressed breast. The images are then synthesized and reconstructed. So what you wind up with is, imagine, a CT. This is basically a CT of the breast. Of course, the point here is that it's been created with way lower radiation. But that's kind of what you can imagine this is, slice by slice by slice imaging of the breast. And you can imagine this has been a great boon for breast, because now we can see through the slices. This helps us to decrease our false positive rates because we're literally able to see 0.1 to 1 millimeter thickness slices. We have improved visualization of the lesion margin, and we have improved visualization of the superimposed tissue to determine whether is this overlapping tissue or tumor. Because as I described to you and showed you, cancer is white on white. We're looking for something which is white on top of dense breast tissue or fibroglandular tissue, which is also white. So it helps us to improve that resolution. Furthermore, where would this be helpful? This would be helpful for dense breast cases where it's extremely dense. We're able to go through slice by slice, and it would help us with detection of small cancers, for example, DCIS, or invasive cancers, which are smaller than 2 centimeters. And it reduces our callback. Because we are able to go slice by slice, we are going to call back less for that. This is just an example of a Hologic unit. It's not that I support one company over another. It's just to show you an example of a mammogram unit. And so on the left side is the console. On the right side, you see the paddles and where the woman and the patient would be placed in order for the compression of the breast and image acquisition. So here we have a patient. It's a 24-year-old patient with left breast enlargement. And what I want to clarify here is actually, is this a male or a female? This is actually a male. And the point I bring to you is that of all the breast cancer cases, only 1% are in male. So obviously it's a very, very small number. But nonetheless, the American Cancer Society has estimates for men, about 2,600 new cases of invasive cancer in men this year, and 530 may die from that. The differential here, which is important, is cancer versus gynecomastia. We have men come in, lots and lots of men who are coming in because they feel an enlarged breast, they feel a lump, and majority of the times it ends up being gynecomastia. So this is just to bring to your attention, this is not just a quote unquote problem of the woman, this is also can be a problem for men as well. Here is a case of a 59-year-old female who presents with the left breast mass. And I show this image to you just so that you can see this is actually an example of implants. These are silicone implants that we are seeing here. They are under the muscle, and then there's a density at the top of the breast. And what I want to bring to your attention is that these implants are silicone. However, there are different types of implants. There's saline. They can be located in different places, under the muscle, over the muscle. And there is an issue of rupture. And so as part of our evaluation for patients with implants, we look for rupture. A silicone implant can be ruptured intracapsularly or extracapsular. that just means that the silicone is spread to the lymph nodes. Or saline, this would literally be seen on physical exam because you would see that it had immediately just become smaller. The point is, even patients with implants can have a biopsy, stereotactic, ultrasound, MRI. We can do these things. And implants are not considered to increase the risk of cancer. In this image that I showed you, the density that you saw is actually not cancer. In fact, that is just silicone, which has spilled out because the implant ruptured and now there is silicone in these lymph nodes. So again, the message is early detection saves lives. So get your screening mammogram today. Thank you very much.
Thank you, Shweta. It was a great talk. Now, since we are running a little late, we'll address the questions at the end of all the speakers after they speak. And I would like to introduce Dr. Mamta Singhvi, who is going to come and talk to us about prevention of cancer. Let me say a few words about Dr. Singhvi. She is a very accomplished speaker. She is a board-certified radiation oncologist and public health specialist from Harvard. She has been a leader within many national nonprofit organizations, including the American Association of Physicians of Indian Origin, and advocates for youth, and has traveled extensively through Cure Cervical Cancer and American Sexual Health Association to raise cancer awareness and promote wellness. She's an avid writer who has blogged for the Huffington Post on topics ranging from politics to sports, vaccinations to racial disparities. Dr. Singhvi is passionate about marrying Eastern and Western health practices and strives to guide patients and the general public on how to live happier, healthier, with more balanced lives. Beyond this, she's on the faculty of UCR School of Medicine, is a certified yoga teacher, a vegetarian foodie, and a lifelong pianist. We are honored today to have Dr. Mamta Singhvi speak to us. Thank you, Dr. Singhvi.
Thank you so much. I want to start by saying thank you to the organizers, Dr. Anjali, Mr. Gaurav, the board president, who we haven't gotten to meet, but Dr. Basu Ray. I want to thank my fellow speakers, as well as the moderator, Dr. Samadar, and of course the audience, both in India, the United States, and everywhere else in the world, for being here for a topic that I'm deeply passionate about. So I'm going to try to share my screen. Hopefully I'll be able to. All right, perfect. Hopefully you can see that.
We can see the presentation and hear you. Please put it in the screen, slide share mode. Full screen.
Full screen. It is in full screen.
For some reason, we are not able to see it in full screen. Is it okay if I run the presentation for you?
Sure, that'd be great.
All right. Just give me a moment.
So as we're setting that up, I just want to start with, yes, I'm very proud. I'm born and raised in the United States to Indian parents. Really grateful for my upbringing and my education at both UCLA and Harvard.
I think we lost connection with Dr. Mamta. Just give us a moment till she joins back. In the meantime, can we take a few questions from the audience, please?
Absolutely.
A couple of questions here. The first question, I guess, is directed towards Dr. Tilak. Association, is there any association with of breast cancer with color of skin or ethnicity?
Yes. So there are these ethnic groups, especially the Ashkenazi Jews, who have a very, very high risk of hereditary breast cancer. And it is very well known that when these patients, the screening programs are much more tighter, and they are the family history runs into sort of generations, and they are followed up closely. As regards skin color, the skin color, especially of breast cancer alone, the incidence rates are much higher in the Western countries as compared to the Middle East and the Eastern countries, whereas the incidence is close to 150, 165 per 1 lakh, whereas in India it's only about 50 to 56. But apart from that, it's mainly due to the habit, but not because of the color of the skin. However, the melanoma, etc., there are a few other cancers that are more common among the whites and color of skin. And apart from breast cancer, the ethnicity, the Eastern Asians, the very Japanese, etc., they're prone to stomach cancer, the nasopharyngeal cancer. And among the lung cancer, there are subtypes which are more common, the EGFR mutated lung cancer, which are more common in the Eastern the population. So that's about the skin color and the ethnicity.
Thank you so much for answering that question. Dr. Mamta has joined us back again. So let me just try and bring the presentation over here so that we can start the session with Dr. Mamta. Dr. Mamta, my request to you is, as I'm running the presentation, please let me know when I should move the slide.
Sure. I don't see the slideshow yet. Is that up? Perfect. Okay, so I just was saying that, yes, I was born and raised in the United States, and I'm proud of my education here, but also deeply, deeply proud and really respect my roots back in India. I had the good fortune of deepening my yoga practice in Rishikesh for several months relatively recently. So my goal today with this talk will be to blend the logic, the rigor, the scientific critical thinking of the West with the insight and the spirituality and the traditional healing forces of the East. So that is the goal as we continue. I will start with a brief overview of breast cancer and then step back and expand the perspective. So we've gone over most of this. We've gone over the statistics. In the United States, 1 in 8 women will have breast cancer. In India, every 4 minutes, someone is diagnosed with breast cancer. What I want to jump down to is the prognosis. So prognosis simply means what are the chances that the woman who is diagnosed with breast cancer will be alive at the 5-year mark. So I want to point out the difference. In the United States of America, that number is 80%. 80% of women, on average, will be alive at 5 years post-diagnosis. In India, however, that number is down to 60%. So you must be wondering why there is a discrepancy, and hopefully as we continue the talk, we'll be able to understand why that is and what we can do to bridge the gap. Next slide, please. So stepping back, there's been globally a turn of events when we look at medicine and healthcare historically. So as it naturally is, when we improve the management of infectious disease, such as malaria, tuberculosis, polio, people start to live longer, and so chronic lifestyle diseases start to rise. By that I mean diabetes, high blood pressure, and of course cancer. And that shift in diseases is a result of westernization, urbanization, modernization, and with that comes improvement in public health. So we're not seeing as many infections because we have improved sanitation, improved hygiene, and improved vaccination. Yet the flip side of that coin is that these developing countries have little access to preventive care, and they have more exposure to health risks. So there's air pollution, nutritional deficiencies, lack of anti-smoking laws, and of course also these developing nations have limited resources to pay for very cost-prohibitive treatment, including things like chemotherapy and radiation. Next slide, please. So now honing in specifically on India, historically speaking, until relatively recently, cancers have been due to infections. So by that I mean cervical cancer, which is linked directly to HPV or human papillomavirus, or liver cancer, which is linked often directly to hepatitis B. However, as India has advanced economically so rapidly, These cancers, secondary to infections, have given rise to cancers of the affluent, so more Western cancers. And that is because the risk factors for those affluent cancers are basically Western lifestyle. People are becoming more sedentary, smoking and drinking more, gaining weight. And so we're seeing more breast and colon cancer. And what I want to say, the main takeaway point is that India is actually at a very pivotal inflection point, because currently it has the highest rates of both the cervical cancer and the breast cancer in the entire world. So it's at this intersection where we see both the cancers of the developing world and cancers of the developed world. Next slide, please. So given this massive toll of chronic lifestyle diseases, and not just cancer, but diabetes and high blood pressure, heart disease, in my humble opinion, the only way forward for a country of such huge proportion and such rapid economic development like India is through prevention. So that's what I'm going to focus the next few minutes on. So why do I believe prevention is key? We've gone over some of the statistics. Worldwide, there's about 15% of deaths that are attributable to cancer today. Unfortunately, that incidence is expected to rise by about 70% over the next 2 decades. And that is because countries like India, countries kind of throughout the world who, again, are rapidly developing economically, are just starting on the cancer curve. And that is because Western lifestyle is taking hold in these nations. In India, for every 2,000 women who are diagnosed with cancer per day, 60% of those cancers are unfortunately at advanced stages. And that is precisely the reason why I said that in America, 80% of patients who are diagnosed with breast cancer will be alive at 5 years. However, in India, only 60%. And that is because when you diagnose a woman with later stage breast cancer, or in fact any cancer, unfortunately, we just don't have the tools to be able to treat her and cure her as effectively. So when you're diagnosing at advanced stages of cancer, we're reducing the survival rates, and we're also, as a byproduct, increasing the treatment costs, because later stage cancers generally mean more radiation, more chemotherapy, more targeted treatments that are very, very cost prohibitive. And the most sobering fact that I'll share with you today is that India, unfortunately, has the highest incidence to mortality ratio of any country in the world. And in layman's terms, all that simply means is that the vast majority of people who will be diagnosed with cancer in India, compared to every other country in the world, will die from that cancer. So that is where I'm going to stop with the negative talk, and I'm going to start to hopefully give us hope as to what we can do. Previous slide, please. Not ready. The last point is the most, I think, hopeful point to be celebrated, is that cancer is not something that we can just blame on bad luck. It's not just genetics. As Dr. Tilak pointed out, lifestyle and environment actually contribute to at least 70 to maybe 90% plus of the risk of developing cancer. And in fact, a really incredible study out of AIIMS in Delhi says that in India, at least 70% of all cancer deaths are preventable. And that is something that I think we really need to be focused on and leverage. So prevention guidelines. Dr. Tilak went over a lot of this, but I want to share a few definitions with you. There's many ways to prevent cancer. So we're going to start with primary prevention. Primary prevention simply means that we prevent the cancer from ever even occurring in the first place. So how do we do that? We do that with things like vaccinations. Currently, there are 2 vaccinations against cancers. One is the hepatitis B, which prevents against many cases of liver cancer. And then there is the HPV, or human papillomavirus vaccination, which prevents against cervical cancer. Other ways to primary prevent cancer are through proper nutrition. So a very interesting study came out that said that young women, teenagers, who eat the most amount of fruits in their young years actually lower their risk of breast cancer by 25% throughout the rest of their life. Then we have secondary prevention. Secondary prevention simply means, as a medical community, we are screening the population to see if we can pick up cancer early. If we pick it up early, we can effectively treat it and we can cure it. Examples of secondary prevention techniques include what Dr. Kukreti Singhvi talked about, such as mammogram for breast cancer and pap smear for cervical cancer. Next, we have tertiary prevention. And tertiary prevention's definition is that when a woman or a man develops cancer, how do we make sure that we are effectively treating so that the patient can have both quality and quantity of life? We want that patient to live well and live longer. And so with tertiary prevention, I want to focus in on physical activity. We know that studies have shown that exercise post a diagnosis with breast cancer has actually led to a 20% decrease risk of death. So by simply walking every day or any other exercise, we can actually decrease the risk of death for a patient who has developed breast cancer. Next slide, please. I want to take a moment to talk about the importance of public policy, and I'm going to give you one case study. In the United States of America, we had already known, and this is back in the 60s and 70s, we'd already known that smoking leads to lung cancer and to many other cancers and diseases. Even though we know that habits are very hard to die, behavior is very difficult to change in human beings. And so public policy really is critical because in this country, the United States, people were not changing their smoking patterns despite knowing the dangers. So only when the federal and state level governments stepped in and started to make laws against smoking, so including taxation on cigarettes, secondhand smoking laws, banning of all billboards that advertised smoking, especially to children, explicit warnings of the dangers of smoking on cigarette packs. Only when they started to implement these laws and execute them did we start to see smoking rates plummet, and naturally several years and decades later, lung cancer rates plummet as well. And to bring this case study back to India, while India has exceptional laws in the books about smoking, implementation is unfortunately lacking. And as a community of healthcare providers and the general population, we really need to start working on implementing these laws. Next slide is right. So health promotion and cancer. I want to end my talk. I know we have to rush through because we have a little bit of time left, but I want to end by talking about health promotion and cancer. So we've talked specifically about prevention with both Dr. Tilak and myself. And that just means how do we decrease the risk of developing cancer? But we equally need to focus on health promotion. So how do we optimize health so that people are not just surviving, but actually thriving? Next slide, please. I want to set the tone of health promotion by sharing with you one of my favorite stories, and this is a true story that comes from one of my favorite books that I highly recommend called The Blue Zones. And this story is about a gentleman who immigrated from Greece right after World War II. He came to the United States and he started to work as a young painter in his early 20s. He got married and he had 3 kids with his wife. He bought a house, he bought a car. He was essentially living the American dream. And that American dream, unfortunately, included westernization and habits such as smoking. So this gentleman started to smoke 3 packs of cigarettes every single day. And by his early 60s, he was diagnosed with lung cancer. Unfortunately, the doctors gave him just a few months to live. And so he decided, instead of getting treatment, which would be very costly and ineffective, he's going to move back to Greece. And when he was in Greece, he was very weak, but he started to be cared by his parents, by his wife, by his friends who would come over, they'd play games. And he slowly started to go to church. As he got more energy, he started to garden. He started to play dominoes. He started to laugh more. And the best part of the story is that when the book was written, it had been 35 years. And this gentleman had survived to 100 and he was completely cancer-free. And so the point of the story is that he did nothing in terms of chemotherapy, radiation. He never took any drugs. He never sought treatment. All this gentleman did was to simply move back home. And this is my final slide that I'll share with you. Next slide, please. I want to talk about returning home. We talk a lot about westernization, and sure, there are boons to westernization and urbanization, but I want to talk about actually returning back to our Indian civilization, because the world over, from America to England to Australia, is talking about how amazing India is. And so we need to start returning to our ancient Indian lifestyle and healing traditions, whether that's yoga and following Patanjali's 8 limbs with the physical activity and the pranayama, with the breathing and the mindfulness and the meditation, or the Ayurvedic principles of limiting animal products, limiting processed foods, and really focusing on fruits and vegetables and other whole plant-based foods. And of course, spirituality. One of my favorite statistics to share with patients is that more than 1,200 studies have shown that those who follow a spiritual path live on average 7 to 13 years longer and have lower incidence of every single disease, including cancer. And so, final slide, please. I'll end with this quote. India is the cradle of the human race. Our most valuable and most instructive materials in the history of man are treasured up in India only. And I want to thank you for your time. And again, I want to thank all those who organized.
Western culture and how we should concentrate on what India had to offer us. Thank you once again. Now I would like to introduce Mr. Wesley Collier, who's going to give a session on yoga. Mr. Collier he's a yoga teacher and has always had an inspiring motive to make a difference in the world through alternative approaches to help and to teach others, a journey that keeps on growing for him. Mr. Wesley received certification in Chinese, herbology and aromatherapy, and also naturopathic medicine. He completed a 6-month internship with Dr. Murtha Champa, a Tibetan and Ayurvedic healer. Mr. Wesley received his 200 CYT in Dynamic Hatha Yoga at Circle Yoga Shala and received 2 teaching certificates in mixed yogic arts and has been taken under the wing of Ruslan Kleitman, which has trained with for many years and also did his 500 hours with Mr. Ruslan as well. Wesley and Ruslan have been taking you groups to India to learn the essence of yoga through tradition. Wesley is co-owner of Arkansas Yoga Collective, and his passion is teaching yoga to cancer patients and to help find relief for the healthy and the not so healthy. Mr. Wesley has been teaching for about 15 years. We are honored and very grateful that Mr. Wesley could join us today. Thank you, Mr. Wesley.
Thank you. Namaskar, everyone. So let's go ahead and get started. So everybody come to a comfortable seated position. And if cross-legged is just not comfortable, you can always just extend the legs or just bend the knees. So just find a comfortable position. You're going to take the palms to the heart and take your thumbs to your sternum and really sit up tall. Now we're going to change keys a little bit and just start to relax a little bit. Wonderful knowledge, wonderful information. But let's just kind of get out of the head right now and just get into the heart. So keep your thumbs to your heart. Really lengthen the spine. Find a comfortable position. Now start to relax the muscles around your spine. Soften your face. Relax your forehead. And soften the legs and feet. Now feel the groundedness of your sit bones. And start to find your breath. And feel that connection from your thumbs to your heart, the warmth, the awareness. And just take all the awareness there. And just breathe into that heart space. Get out of your head for a little bit and get into your heart. And just take several breaths here. No breath technique, just breathe. Just keep your awareness to your heart. Breathe into that space. Okay, softly open your eyes and take your hands to your thighs. We're just going to take a little twist. So left hand goes to right knee, right fingertips behind. You're going to move slowly and calmly. So come back to center and just switch sides. So right hand, left knee or thigh, depends on where your legs are. So the alignment goes, inhale, lengthen the spine. Exhale, take the twist. Come back to center, hands on knees or thighs. And we're just going to circle the torso. Lead with your chin. Go really slow. Take your time. Just breathe slowly and just find a good pace. Let's find the rhythm of the movement and the breath. Good. Now slowly switch directions. Lead with your chin. All right. Come back to center. Inhale, chin up, chest up. Exhale, round the spine, chin to chest. Good. Keep on going. Inhale, chin up, chest up. Exhale, round the spine, chin to chest. Keep staying in that heart space. Really open the chest. Be careful. Exhale, roll and round. 2 more. Inhale, lift. Exhale, roll. All right. Come back to neutral position. Let's check in again. Take the thumbs to the heart, elbows out. Lengthen the spine. Sit up tall, but not too rigid. Relax the muscles around the spine. Just come back to that particular space. Breathe into the heart, the chest, the front side of the body. Stay out of the head and into the heart. All right. Release the hands to the thighs. Now start to circle the head and neck. Go slow. Now, if this is too much, you can always just take the head from side to side. You can switch directions. All right, bring the head back to center. Now shake the head no. Shake the head yes. Now come back to center. Gaze over your right shoulder. Take your chin towards your collarbone, just so you can feel the left side of the neck a little bit more. Good. Inhale back to center. Exhale, switch sides. So gaze over your left shoulder. Bring your chin towards your collarbone. All right. Back to center. Good. One more time. Shake the head no. And shake the head yes. All right. Interlace the fingers. Press the palms towards the ceiling. If that's too much on the shoulders and chest, just bend the elbows a little bit. We're going to do similar to what we did with our knees. We're just going to circle with the arms. Be careful. Doesn't matter which direction because we'll switch. Now, if it's too hard to interlace the fingers, just make a little fist. Switch directions and just find a subtle breath. Keep the awareness to the chest and the heart. Good. Now here, take both hands out to the right side. We're going to lengthen the spine, so straighten the arms. Lengthen the spine, gaze over your left shoulder. Close your eyes for just a moment. Find a little bit of calmness. Okay. Inhale, take the arms all the way up, or bend the elbows. Exhale, left side. Inhale, lengthen. Exhale, gaze over your right shoulder. Close your eyes and find a little bit of calmness. All right. Now just extend the arms up. As you exhale, just release all the way down. I'm going to come into all fours. Now here, hips over knees, shoulders over wrist, and spread the fingers. Inhale, chin up, chest up. Exhale, round the spine, chin to chest. Good. Be careful, take your time. Good. Again, breath goes, inhale, chest up, chin up. Exhale, round the spine, chin to chest. Good. All right. Neutral position. We're going to take the right foot out to the right. The torso comes all the way up. Now, right hand towards the right knee. We start to get a little side bend here. Now, left hand behind the head and just bend out to your right. Really extend that right leg. If this is too much on the chest or the shoulder, you can just take the hand to the hip. No big deal. Again, close your eyes, if possible, with balance, and just rest here. Take the hands down, all fours. Now, right leg comes back and up, and we're going to take that right foot out to the left. So behind you. Demonstrate a different angle. Right foot out to the left. Left elbow down. Right hand goes out to the left. So kind of difficult stretch here, but you can find the balance here. And breathe. Okay. Come back to center. All fours. Now, left foot out to the left. Come all the way up. Left hand towards the left knee. Right hand behind the hip. And take a little bend out to the left. Now we're trying to relax, even though we're in this awkward position. Open the chest. Remember, if it's too much, you can just take the right hand to the right hip. Maybe close your eyes and rest a little bit more. All right. Now, palms down. Left leg comes back. And you're going to take the left leg out to the right. Just like we did, just switch sides. Left elbow comes down. Right hand over to the left. So really walk that right hand out to the left. Okay. Good job, everybody. Come to all fours. Now, here, no fancy way, just going to lie down. Now, if you have a yoga mat, we're going to take the feet in the corners of the mat. If not, just on the floor. Make sure I'm not going over the top. And lie down here. Now, take the feet in the corners of the mat or separate the feet about shoulder distance apart. Arms by your sides, palms facing up. And close your eyes. Soften what needs to be softened. Relax what needs to be relaxed. So relax your forehead, your cheekbones, your cheeks, and especially your jaw. Maybe move the jaw around a little bit to release the tension in the face. Feel the heaviness of your shoulders, your arms, back legs, and feet. And completely let go. Surrender. And this melts into the mat. Relax. 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 So no need to control the breath. Just let the breath be free. And just notice that it's functioning natural. So no need to control it or change the breath. Just relax here. Okay. Now, start to wake up the body and wiggle your fingers, your toes, ankles, and wrists. And slide the feet together, legs together. Now take the arms up and back, tops of the hands on the ground, stretch, reach. And roll over on your right side. Now use your left hand to bring yourself up to seated. Come to a comfortable seated position. And take your palms to your heart. Roll the shoulders back and down. Close your eyes one more time. Rub the palms. And place the hands over your eyes. And open your eyes in the darkness of the palms. Good. Release the hands to your thighs. And just gently check in and see how you feel. Namaskar, everyone. Take care.
Thank you, Mr. Collier. That was very, very relaxing. And at this point, we'll go ahead and take some questions that the audience has. Seems the audience has been listening very patiently. So one of the questions, which was, it is probably for Dr. Tilak or Dr. Mamta Singhvi, if a teenage girl has lump in breast, could it be cancer? This was one of the questions. Any one of you can answer that and take it.
Dr. Mamta?
Sure. I would say in my experience, I have seen very young women developing cancer as early as early 20s. I've never seen a teenager. I'm not saying that it's not possible, but I would say more likely than not in medicine, we say, you have to go with what is most likely. So the worry may be there. It's unlikely anything dangerous. If there is indeed lots of concern, then I would say go see the primary care physician.
Thank you. The next question was actually addressed already by Dr. Shweta Singhvi. Can men have breast cancer? So I think we'll let that pass for now. I think she addressed it. The third question was, how do we get rid of agrochemicals used on foodstuff?
So the recommendations are very, very simple. Washing with just brine, or what is known as salt water, is good enough to wash away the chemicals. And for patients who are undergoing bone marrow transplant, etc., we generally tell them to avoid. But if needs to be given, then we wash them with potassium permanganate. Very small few crystals. Just make it baby pink color in the water. and put the vegetables in that and wash it. Vinegar has also been tried. So 10 ml of vinegar, 90 ml of water. Just leave the vegetables and fruits in that for some time, and they can be taken out and washed, and the agrochemicals will be off. Best, of course, is to peel them and then consume them.
Great. The next question was, I'm assuming my mother, aunt, and grandmother died of cancer. What should she do? I'm assuming it's breast cancer. So,
Shweta.
I can take this. So basically, we would need to know the ages for
absolutely.
when the breast cancer was diagnosed. And then based on that, we would calculate the risk. So as I'd explained, we have models for risk, but we would take your age, weight, history, and then we would have a calculation. And so what you need to do, basically, get in with your primary care, give them this history, they will run a calculation. And so, for example, if your mother was diagnosed when she was 42 years old, then you would start 10 years before, which would be 32. And then you would also be placed on alternative 6-month mammogram, then 6-month MRI, again 6-month mammogram, because you are high risk after these calculations. And so we would need you on a plan like that.
Great. The next question was, there was black color discharge in perimenopausal stage. Is that dangerous? Should it be investigated right away?
So if black color discharge is there, we would want you to come in. When you come in, we would have you start with a mammogram. Black color is tricky because it could be blood, which is very, very old. It's turned from maroon to brown to now black. So it raises the questions while it's not flat out red. We would continue to do the mammogram. We would do ultrasound. If it's available, we could do a ductogram, an MRI. But we need to investigate that. There can be an underlying finding there, but we don't know that until we figure it out.
Okay, I think this is addressed to Dr. Shweta. What are some examples of new breast imaging technology that are improving detection or making it more effective?
So there are a lot of works and technologies in the pipeline. To begin with, there is something called contrast-enhanced mammography. So as you saw right now, mammography right now is without contrast. We simply take images using radiation. But along with contrast, the whole idea is that in lifetime, you're able to put in contrast, which hopefully should go to the tumor and then allow us to better see that along with the mammography. Another example is technology which is in development. I've been fortunately part of this before, which is using near-infrared technology, which is optics. And what this uses is light, which is near-infrared. It's completely non-invasive, and it uses a probe, kind of like a handheld probe, like an ultrasound, and allows you to see molecular markers. And that basically means it's a non-invasive way of seeing markers which are within the body, for example, blood and lipids, fats. And it allows us to identify, number one, the cancer, and then separate it from other types of masses. So these are just examples of two of the technologies which are in the pipeline right now, but there are many others which are being worked on in modifications, for example, modified MRI protocols.
Okay. What is the role of nuclear medicine test in the staging of the disease for effective prognosis? I think that's addressed to you too.
Right. So when we talk about nuclear medicine, I'm presuming that we are talking about PET-CT scans. That's a really good question, and it's a complex topic. I have seen that there are patients who are receiving their chemotherapy treatments and they get PET scans. And the purpose here is, remember, so the breast cancer starts in the breast, but it moves. It moves to the lymph nodes. But then, unfortunately, it can also move to the bones. It can metastasize to other sites. And so if we feel, for example, someone has gotten a bone study, and we are now seeing lesions, which means we are seeing that the cancer has spread to the bone, we will get them a PET-CT because now we're worried that it's gone. Or if we have any inclination that this thing is spreading, or it's a tumor which is rapidly progressing, we will get that. But that's something that we would determine if we had an inkling that it's spread. And how would you know that? Well, if it's spread to the axilla or if it's not. If it's not, you're okay in the sense that it's better. But if it's spread to the axilla, then we may start asking these questions. We do MRI, which starts with helping us, and then we may move to the PET CT. But that would be, and the bone scan would be two of the main techniques that you would want to see if that would be helpful.
Thank you, Shweta. And this question is for Mr. Wesley Collier. Can pranayama be done lying down in bed?
Yes. It just depends on which one you choose or prescribe, but yes, you can. I would recommend probably sitting up a little bit more. Maybe doing something like having your knees bent or something like that. So it's a little bit more off your abdomen and things like that. But I think it's fine to do particular ones lying down. Yes.
Okay, one more question for you, sir. How soon after surgery can yoga be done?
Oh, that's a good question. I would say probably to wait. It just depends on how many surgeries you have. But if it's just on the left side, I would just work on that slowly after a couple months. You don't want to go straight into it. Also, there's doctors usually know some simple exercises that you can do just to kind of strengthen and open up the body a little bit more. But I would probably recommend 6 weeks to 2 months of just more healing, and just kind of if you want to do some sort of exercise or something to get circulation going and all that, you can just walk.
Perfect. Thank you. I would like to once again thank our audience, Anjali, Gaurav, Dr. Indranil Basurai, the American Academy of Yoga and Meditation, and all our amazing speakers, Dr. Tilak, Dr. Mamta Singhvi, Dr. Shweta Singhvi, and Mr. Wesley Collier for giving this wonderful presentation. I think it was very informative. And thank you for giving me the opportunity to moderate this session. I will hand it over to Anjali. Thank you, Anjali.
Thank you, all the esteemed speakers here. We enjoyed this session very much. We're getting some very endearing comments and requests also for this program to be done again in Hindi from our viewers in India, because for them it was a little more educational. Especially the presentation given by Dr. Shweta, they would want to understand it a little more clearly in Hindi probably. So we will definitely reach out to you for a Hindi version of these programs, because honestly speaking, a lot of people here who are associated with us, as in sense of therapies that we give here, belong to rural area, and they connect with us on online mediums through their mobile phones. So I'm sure they would want to hear this out in Hindi. And we are doing through the American Academy also, we are reaching out to a lot of survivors and patients of breast cancer. So I think they all will benefit a lot from this. It was a wonderful session. And on behalf of American Academy of Yoga and Meditation, I thank Dr. Anjana Samadar for organizing this wonderful breast cancer awareness session here. The session is available for viewing even after the live session, because we have a live streaming and recording happening, and it will be posted on YouTube and Facebook channels of American Academy of Yoga and Meditation, and also Ganges Mississippi Dialogue. So feel free to watch this again over there. Our next webinar, as the scroller is going on, will be on migraine, another very, very important topic, and we had got these requests to do a program on migraine, and we will have people from Ayurveda and acupuncture and yoga coming and talking on this. So please do join us next week, same time, on YouTube and Facebook channel. Thank you so much all, and good night to everyone in India. Good day. Namaskar.
Namaskar.
Thank you.
Thank you.